All right, well, good afternoon, everyone. We're going to go ahead and get started because we have a lot of material to cover today. So welcome to today's webinar, and then thank you for joining us. My name is Dr. Alexandra Vandenberg, and I'm the Associate Director of the Michael and Susan Dell Center for Healthy Living, and also Professor for Health Promotion and Behavioral Sciences at the UTHealth Houston School of Public Health in Austin. And so today's webinar is hosted by the Michael and Susan Dell Center. And the vision of the center is healthy children in a healthy world, with a mission to advance health and healthy living for children and families through early and impactful interventions. Our faculty, research projects, and communication initiatives intend to, first of all, one, create new research ideas and trainings for public health students. Two, communicate evidence-based products and outcomes to researchers and legislators. And then lastly, to connect with communities and other public health organizations. I would like to recognize the Michael and Susan Dell Foundation for making all our center activities possible, including today's webinar. And then a lot of the center's work, including our center resources, can be found online. And on this slide, you'll see a QR code on your screen that will allow you to access all our health resources. If you can go to the next slide, please. And in addition to the previous resources, we also, or our center leads the Texas Research to Policy Collaboration project, which creates legislative related resources which are described on this page. And again, you can just scan the QR codes to get more information about all these different resources. So before we get started, we have some brief housekeeping announcements. First of all, this webinar is being recorded and will be archived along with the presentation slides on our website. And then secondly, if you have any questions during the presentation, please enter them into the chat box. And then at the end, we'll have some time for Q&A. And we'll go over your questions. This slide, TEPHI. We are excited to host today's webinar in partnership with the Texas Epidemic Public Health Institute, or TEPHI. And TEPHI is working to prepare Texas for future infectious disease outbreaks, ultimately to keep Texans safe and strong. So we invite you to visit the TEPHI.texas.gov to learn more about TEPHI's work and how you could get involved. Next slide, please. Okay, so at this time, I am very excited to introduce our speaker today, Dr. Catherine Troisi. And Dr. Troisi is an associate professor in the divisions of Management, Policy, and Community Health and Epidemiology at UTHealth Houston School of Public Health. And she's also the coordinator for the Leadership Theory and Practice Certificate, having previously served as the assistant director at the Houston Health Department. She teaches courses in public health and leadership with research interests in infectious disease epidemiology. She holds a BA in chemistry from the University of Rochester, an MS in biochemistry from Michigan State University, and a PhD in epidemiologic sciences from the University of Michigan. She completed the National Public Health Leadership Training in February of 2011 and received the UTHealth School of Public Health Community Service Award in 2013 and 2019, and the Excellence in Teaching Award in 2017. So lots of awards. She also received the American Public Health Association Advocacy Award in 2015 and was elected to the APHA Executive Board in 2017. She is recipient of the 2018 Association of School and Programs in Public Health Academic Public Health Practice Excellent Award. She's a board member of the International Network of Epidemiology and Policy, as well as many local and state public health advisory boards. She has had 20 op-eds published in Texas newspapers and has had over 4,000 media hits on COVID and other infectious disease topics. So she is definitely an expert, and we are very excited to have her talk to us today. And the title of her presentation, as you can see here, is Immunizations, Vaccines Cause Adults. So Dr. Troisi, I will hand it over to you now.
All right, thank you. I'm delighted to be with you here today. An important topic, but a bigger one than I can cover in this hour, 45 minutes. So, please put in questions in the discussion link, or question link rather. And I will try to answer them afterwards, because I'm just not going to be able to go into a lot of detail. But immunizations, we've heard a lot about them lately, a political issue, and yet, oh, I'm sorry, I'm going to tell you about how vaccines, the topics that I'm going to cover. Basically, a smattering of everything about vaccines, how they work, how they're licensed, how we know they're safe, some myths, what are current recommended immunization schedules, how public health law affects immunization requirements, what coverage looks like right now, and how can we as immunization advocates promote immunization in our communities. So CDC in the early 2000s made a list of the top 10 achievements of public health in the previous century, in the 20th century. And vaccines were one of those top 10. You can find in the link what the other 9 were. And this table shows you some diseases that at that time we had vaccines against. We have more now. And what the record number of cases was before the vaccine. So it's different years for different diseases, and what we saw in 1998. Smallpox, there used to be 48,000 at the max cases in the United States. We have eradicated that disease. There are 0 cases, 100% decrease. Diphtheria, 175,000, 1 case in 1998, 100% decrease. And you can look down this list and see what an achievement this is in terms of preventing illness and death. So we have, as I mentioned, eradicated, gotten rid of through the whole world, one infectious disease, that is smallpox. It was declared eradicated in 1979. We have as a target polio. We get close, and then because of different issues, mostly again political and conflict zones, we've gotten close. We haven't quite gotten there yet, but certainly the number of cases of polio is much decreased from what it was, say, in the 1950s. We are also targeting measles and rubella, that is German measles, for elimination of transmission. What that means is in geographic areas, maybe not throughout the whole world, but in geographic areas. And then there are also targets for elimination as a public health problem. What this means is that a specific disease reduction target. So we may not do away with it completely, but we really want to decrease the cases. And you can see here what those diseases are that we have effective vaccines against. So how do vaccines work? Well, basically, they are showing your body an infectious agent, usually part of an infectious agent. And so your immune system sees this. It says, wait, this is not me. This is not my body. It shouldn't be here. I'm going to make some antibodies and some T cells against it. And so it does that. And without you getting sick, because it's only part of the virus or bacteria. And but your body has an amazing capacity to remember what it's been exposed to, what it's made antibodies to, and triggered the immune system. And then moving on, later on, if you're exposed, it'll ramp up really quickly and prevent you from getting ill, or at least from getting severe disease, being hospitalized, or dying. So that's a basic way that all vaccines work. There are different types of vaccines. Some take the virus, in this case, hepatitis A, rabies, poliovirus vaccine. There's actually 2. This is the inactivated, and flu. So it takes the whole virus, it kills it, and then you have that injected into your body. And again, your body recognizes it as foreign, makes an immune response, and if you're exposed later on, and it can be years and years later, your body remembers and you're protected. We also have subunit vaccines where instead of the whole pathogen, just parts of it are put into the vaccine, but the parts that your body makes antibodies to protect you. Some of those are even made through recombinant technology, for example, in yeast. They're the Haemophilus influenza B, human papillomavirus, pneumococcal vaccines, flu. Again, there's a number of type of flu vaccines are some examples of subunit vaccines. There are two vaccines where we actually don't even inject the pathogen itself. It's the toxoid that causes the disease that is in the vaccine, and diphtheria and tetanus are examples of those. And then we have what are called live attenuated vaccines. These have the virus. These are all viruses, but they're weakened so that they can't cause disease. But they do a really good job of provoking the immune system so that you have good protection should you actually be exposed to the wild type virus. And then, as you may have heard about, we have a new type of vaccine, mRNA vaccines. It actually had been in development for a number of years. The COVID vaccine was the first time there was a licensed vaccine using mRNA. In this case, we inject messenger RNA, which codes for proteins. Your body takes it in, your cells take it in and produce that protein. Then your body says, wait, this protein isn't part of me. It's a foreign protein. We're going to make antibodies against it. It has been very successful with the COVID vaccine, and we are looking at using that technology for other diseases that we have not been so successful with developing vaccines for various reasons, for example, HIV. So you're going to be hearing more about mRNA vaccines. So there are a number of benefits of immunization. First of all, they protect the person who is vaccinated. We can even protect people from cancer through hepatitis B vaccine, which causes liver cancer, and human papillomavirus vaccine, which causes a number of cancers. So vaccines don't just protect against acute disease. They can, some of them can protect against cancer as well. It's also, vaccines are important because they protect the community and stop the spread of disease because people are immune, so they can't get infected and spread the, I'm just going to say virus because I work with viruses, but it could be bacteria. And there are some people who can't be vaccinated. So if the community is vaccinated, that protects them. There are some people who have contraindications to vaccines, protects them even though they're not vaccinated. As one ages, like many of your organs, your immune system doesn't work quite so well. So even though we immunize older adults, they may not respond as well. They may not be as protected. That's also true with very young children whose immune systems are not mature yet. So by having other people who can be vaccinated protected, that protects people in the population who may not respond as well to the vaccine. We can also no vaccine is 100% effective. And so someone who's been, even if they're young and healthy, may not have as good a immune response to a vaccine. We're protecting them. And then there's even there was just a paper published, I think in the last week, showing that people who are fully immunized may be protected against diseases such as Alzheimer's disease, which may have an immunological component. So what's in a vaccine? Well, first of all, what's needed to provoke immunity? Those are the antigens, the part of the virus or bacteria that your body makes antibodies to that protects you. And then some vaccines contain adjuvants, which make the vaccine more potent. Some vaccines, not all, have preservatives and stabilizers so that the vaccines can last longer, have a longer shelf life. And then there are also some materials used during the production of the vaccine. Again, it depends on which type of vaccine it is, but sometimes viruses are grown in cell culture. If it's a live attenuated vaccine, you need to have something to attenuate it, to weaken it. Excuse me. And then sometimes antibiotics are added, again, to keep it sterile. So how does a vaccine get licensed? Well, first of all, there are a number of phases, 4 phases of vaccine development. The first is a very small group, 20 to 100 healthy volunteers. Sorry, just let me, my allergies are out of control, I will admit. The first question is, in this phase 1, is the vaccine safe? Does it seem to work? It's a small amount of people, but does it seem to work? Are there serious side effects? And it may look at different doses of the vaccine, what exactly is needed. You then move, assuming those answers are what you want to hear, you move to phase 2. Those are several hundred thousands of volunteers. And that's looking at what are the short-term side effects. And I am so sorry. And is the vaccine doing what you want it to do? That is it making your body produce antibodies? Phase 3 are even more people. This is looking at efficacy of the vaccine. Does the vaccine protect people who are vaccinated? Who are vaccinated compared to a placebo group? Again, looking at side effects, and does the vaccine, again, do what you want it to do? So assuming all those are good results, it goes to FDA for licensure. FDA looks at that information. Is the vaccine safe and effective? What's the best dosage? What's the best scheduling? And FDA, based on all these data, decides whether to approve it. In some cases, it can go to another committee made up of public health and vaccine experts looking at it. After it's approved by the FDA, the FDA doesn't stop there. It continues to look at the vaccine. It looks at different lots of the vaccine, making sure there's consistency across that. Is the vaccine potent? Is it pure? So again, once the licensure occurs, that doesn't stop what FDA is looking at. So once FDA approves a vaccine, it goes to the Advisory Committee on Immunization Practices. They are a group of experts. They recommend, based on the data from these clinical trials, how safe and effective the vaccine is, looking at different ages, how serious the vaccine preventable disease is. For example, we don't have a vaccine against the common cold. Now, there's a number of reasons for that, but one of them is that people don't usually die. You might feel like you are, but you don't die from a common cold. So it's the benefit ratio is just not worth it. And looking at how many people would get the disease if there was no vaccine. If it's only a handful of people, it's may not be worth manufacturing a vaccine or recommending it if a lot of people are not at risk. I was asked recently about the malaria vaccine. There've been a number of local transmission events in the United States. One just reported from Maryland. And the reporter asked me about why don't we recommend the malaria vaccine in the United States? It is recommended for children in Africa and other areas where malaria is prevalent. Well, it's simply not worth it in terms of cost and benefit because there's so few cases in the United States. After ACIP recommends a vaccine, it goes to the CDC director, who then approves it, and it becomes official guidance from CDC. It can also lead to the vaccine being part of the immunization schedule. So, as I mentioned, once a vaccine is licensed, there is continuing monitoring of the vaccine for safety and side effects. And one of the main ways we do this is through the Vaccine Adverse Event Reporting System, VAERS. It's anybody can report to this, and the idea is to detect if there are some very rare side effects that you wouldn't have seen even if you have 100,000 people in phase 3 trials. If it happens in 1 in a million people get the vaccine, you're just not going to find it till it goes out to the public at large. So as I mentioned, anybody can report to VAERS. It's on, I believe it's on the CDC site. You can certainly Google it if you want to report something. Looking at what the VAERS data look like, vaccines can actually be taken off the market. This happened with an earlier rotavirus vaccine, where there were some reported cases of intussusception. So the vaccine was taken off. This is an earlier version. This is not a case with the current rotavirus vaccine. Actually, data, when we looked at the data later, it looked like those cases were not actually due to the vaccine. But obviously, we want to be very careful that we are not giving vaccines that have serious side effects. VAERS can also be used to look at lot safety, and is there a particular lot that is causing issues? It does have some limitations. First of all, not everybody reports to it, or there might be increased reporting because of media attention to a vaccine, so that the data can be incomplete and inaccurate. You also don't have a denominator because you don't know how many people received a given vaccine. And it's important to remember that VAERS can't determine if an adverse event is actually due to the vaccine. I personally got a tetanus diphtheria booster. It's recommended every 10 years on Monday. If I had been hit by a bus on the way to work today, 2 days after this vaccine, that could have been reported. I was not, but that could have been reported to VAERS. Now, it would be really hard to hypothesize why being hit by a bus is related to the vaccine I got on Monday, but that could go into the data system. I want to spend just a minute, because I am not a lawyer, on public health law and immunizations. There was a very famous Supreme Court case in 1905, Jacobson versus State of Massachusetts. Now, the U.S. Constitution, in the 10th Amendment, it's the States' Rights Amendment, and it says that any power not specifically given to the federal government is a state's right. Public health, in all of its aspects, falls under this state's rights. That's why we see different applications of not just vaccine law, but any public health intervention. And we certainly saw this during COVID with masking based on the state. So again, in 1905, famous case, Jacobson versus State of Massachusetts. There was a smallpox epidemic. Jacobson didn't want to get vaccinated. Now, he actually didn't have to be vaccinated. He could have paid a fine of $5, but he did not want to do that. He was claiming basically religious freedom and body sovereignty. The Supreme Court ruled that given this tension between personal liberty and public safety, still seeing that today, that the state had an overwhelming interest in controlling this smallpox epidemic. Smallpox kills about 30% of the people infected, so it's very serious. And Jacobson lost that case. He ended up paying the fine, not getting vaccinated. So this was really the public health law precedent for immunizations up until COVID. During the COVID pandemic, there were 2 court cases that had contradictory rulings. Again, it's not just an immunization. We're seeing that with the Supreme Court. So in the Biden versus Missouri ruling, the court ruled that CMS, Center for Medicare and Medicaid Services, could require nursing homes to require their staff to be vaccinated. And because CMS has in their regulations, they can control what they require nursing homes to do. So that was a pro-vaccine ruling. However, OSHA also tried to have a vaccine mandate for workers in certain industries, and they lost that case. It wasn't so much on the public health law aspect of it. It was really OSHA and whether OSHA had that there were better federal agencies to do it versus OSHA. But again, we're seeing this with the Supreme Court a lot. So I mentioned that vaccines, besides protecting the community, also protect, besides protecting the individual, also protect the community. And we used to call this herd immunity. People objected to the word herd, so we now are calling it community immunity. It has a nice ring to it. And what this refers to is that if enough people are immune in a community, a virus can't spread, or a bacteria. And so for different pathogens, we have different percentages of the community that have to be immune in order for this community immunity to be in effect. This shows you graphically what happens if only a few people are immunized, or if nobody's immunized, or have had the disease before. You could be you were immunized, it could be you're immune because you had the disease. Then it spreads. If some of the community is immunized, the disease can still spread. And when most of the community is immunized, or again has had the disease, there aren't enough vulnerable people, and the disease can't spread. Now, as I mentioned, this number depends on, this percentage depends on the infectiousness of the agent. The probably most infectious agent we know is measles, and in that case, 95% approximately of the population has to be immune to stop spread. For polio, it's about 80%. For varicella, that is chickenpox, 90%. So again, it depends on how infectious an agent is. It's also important to remember vaccines are not just for children. Most vaccines require multiple doses, sometimes just during childhood, sometimes, like I received my tetanus diphtheria booster, throughout the lifetime. And then there are also viruses that mutate very quickly. Flu and SARS-CoV-2 would be two main examples that we, at least for flu, we need to get updated every year and get a new booster. Probably will be the same for COVID. And then there are some vaccines only recommended for adults, for example, shingles and pneumonia. So I'm going to go through a couple common myths that you may have heard. They're one of the most prevalent one, although I'm not sure we're hearing it so much now, is that vaccines cause autism. This was based on a flawed, unethical, and fraudulent study done in the UK. I think it was 97, right around then. And the study, that is simply not true. The study was retracted. The lead author had his license revoked because of this. And there have been a lot of studies since then looking at particularly measles, mumps, rubella, MMR vaccine, and autism. None of them have found a link. And so people have switched from that myth to, okay, maybe vaccines don't cause autism, but babies get a lot of vaccines to protect them, as we want to. And maybe it's better to space them out, that they're being exposed to too many pathogens at the same time. Well, the truth is that babies, right from the start, can respond well to vaccines. And in daily life, unless we're in a sterile bubble, we are exposed to many, many more pathogens and antigens in the environment than are in these vaccines. And, most of us seem to do just fine. And there's no evidence that spreading out the schedule for the vaccination actually improves health outcomes, and in fact may have a deleterious effect because children are susceptible for a longer period of time because they haven't been immunized as quickly. Another myth out there is that vaccines cause the disease that they're designed to prevent, that they can actually cause disease. This is particularly, you particularly hear this with influenza. I hear people tell me that they got the influenza from the influenza vaccine. Well, that if you got the inactivated or the subunit, it's not even the whole virus. It's simply not biologically possible. What is possible is you were incubating flu. You get the vaccine during periods when flu is circulating in the population and happen to be coming down with it. So inactivated subunit mRNA vaccines can't possibly cause the disease because it's not the whole agent. Live attenuated, those are the weakened ones, could possibly, but very, very, very rarely. And even if they do cause disease, it's a weakened form of the disease. So you're not going to, again, be, severe disease, be hospitalized or die. Often we have symptoms after vaccination. Even with placebos, you get a sore arm. And if you do have symptoms, like many of us have after COVID vaccines, it may be a sign that your immune response is actually working. It's geared up and making those antibodies. And as I hope you are convinced of, vaccines undergo a lot of testing before they are approved and continue to go under testing. There's also, and you heard this with COVID, well, it's not 100% effective. You can still get the disease, so why even bother getting vaccinated? Well, there's no vaccine out there that's perfect, and it is true that sometimes you can get, particularly with flu or COVID, because those two viruses mutate very easily. The vaccine may not be a great match for the strain that's around. However, what vaccines do is they protect you against severe disease, against hospitalization and death. And in the end, isn't that what we want to prevent? Also a myth out there that your child you could say is wrongly, that is have greater risk of harm from a vaccine than the disease itself, that vaccines are unsafe. Well, we wouldn't be vaccinating if the risks of natural infection weren't much greater than any risks of immunization. For example, I mentioned the common cold. We don't vaccinate against that because it's not causing deaths. As you saw in that first slide about the top 10 public health achievements of the 20th century, immunization is the best way we have to protect against these deadly diseases. Severe side effects from immunization, although they can happen, but it's very difficult to prove causality. But, it could happen, are very, very, very rare. And your risk of getting the disease and having serious side effects from that and perhaps dying are much greater. And immunization protects, again, not just the individual, but the community itself. So I'm not going to read this to you. You will have the slides. This shows you some of the vaccines that we have and against what illnesses. Just maybe yesterday, last couple of days, we have a new vaccine that's been licensed to prevent RSV, respiratory syncytial virus, in babies. This is really important because RSV can be very, very serious in very young babies. It peaks at 2 months. It's an interesting vaccine. Just like pertussis, we don't vaccinate, well, we do vaccinate the babies with DPT, but we also vaccinate the mother so that the mother makes antibodies, passes those to the baby, and they're around in the baby for about 6 months until the baby gets old enough to be, for their immune system to respond to RSV. I am also not going to read you the next couple slides. You can, I have the site there, and these are all from CDC. It shows you what the current recommended schedules are for children. This is birth through 6 years. This is children 7 to 18 years, and then also one for adults. And it's pretty amazing that we can protect against all these diseases. When I was a baby, that was not the case. We did have smallpox and DPT, but not a lot of these. So let's talk about school immunization requirements. This shows you, and I know not all of you are from Texas, but it varies state to state, country to country. As I said, in the United States, it's a states' rights issue. That's why different states have different immunization requirements for school. And this shows you what's required by Texas for children in grades K through 12. Again, you'll have these slides if you want to look at it more carefully, and the link is there as well. So vaccines, I hope I've convinced you, do a great job of preventing disease, but they only work if people get them. You know, it's shots in arms that matter. Unfortunately, we are probably not where we should be, and that's due somewhat to the pandemic, because during the pandemic, particularly the first year, children are not going for their well child visits where they would be getting these immunizations. And it's not just in the United States. This shows you global coverage. We did see some improvement in 2022. The rates went up, and it's nearly back to the pre-pandemic level, but not where it should be. And you know, you can look at these data for a lot of different vaccines. If you look at U.S. coverage rates, again, you see a slight dip. This only goes up to 2019, so we don't see the pandemic. The CDC data is a couple of years old. But again, not where we want to be. And it depends on, again, what virus you're talking about, because some are more infectious than others. So what do the schools look like? Again, this is data for Texas. You can look it up for any state that you want to find out about, or country. And you can see that, you know, we're not doing too badly. I mean, let's just take DTaP. Almost 94% sounds pretty good, doesn't it? Well, yes and no. I mean, certainly better than 50%. But what happens is those children, that 6% that's not vaccinated, tend to be in specific areas. So it's maybe 94% over the whole state, but there are pockets where the percent that are vaccinated are much lower. So what happens when we have low vaccine coverage? Guess what? We have outbreaks, and this shows you some of the recent outbreaks around the world that have been have occurred in the last couple of years. Again, a lot of times it's measles because that's so infectious, but we had polio virus in New York City. And this decrease in particularly measles, you know, it's an MMR vaccine, but mumps and rubella are not as infectious, is very concerning, because we have had outbreaks, particularly in unvaccinated communities. So why are we seeing this decrease if you have to be vaccinated to be in school? Well, there are exemptions. There is always a medical exemption. If a child cannot medically safely be vaccinated, of course we're not going to do it. So every state has a medical exemption, but there are very few children that applies to. There are some states, that's in the green or gray, that have a personal belief exemption. This means you can, and you'll note Texas is one of them, you can simply sign a document and say your personal belief is to not vaccinate your child. There are also states that have religious exemptions where you can say that your religious beliefs do not allow for vaccination. There are a couple of states that have done away with religious exemptions and never had personal exemptions to begin with. You can see California, New York, West Virginia. These are due to big outbreaks of measles. You may remember in 2014, the Disneyland measles outbreak in California. And because of that, the states just did away with these religious exemptions. So what's the case in Texas? Well, you can always get a medical exemption, as I said. Physician has to sign for it, but parents or guardians can also choose an exemption from requirements for reasons of conscience, including a religious belief. You cannot just say, sorry, I don't have time to take my child to the doctor. However, you don't have to, all you have to say is you have a personal belief. You don't have to verify, I don't know how you would, that that's the case. However, schools are required to keep up-to-date list of students with exemptions in case there is an outbreak. They will know who's at risk. So looking at Texas again, and where do we see the highest, that's the black, rates of conscientious exemption? Well, you can see that it's not evenly distributed around the state, that there are communities that have higher rates, and those are communities that are at higher risk of outbreaks, again, particularly of measles. So why do we have low coverage rates? Well, a major reason is lack of insurance. Texas has one of the highest rates of uninsured. Now, there are programs, vaccines for children, and a adult safety net that covers vaccines for people without insurance. But people may not know about it. You can always get vaccines at your local health department, but again, people may not know about it. It may be hard to get off work to take your child to get vaccinated, etc. We talked about some of the misinformation that's out there about vaccines, very prevalent on social media, and we even have a presidential candidate who is spreading these myths. I mean, not just doesn't believe in vaccination, is actively spreading this information that's simply not true. It may be that vaccines are low priority, unlike when I was a child, when these diseases were very common. Parents just haven't seen it thanks to immunization, but they may not understand that their child is at risk if they should get infected with one of these vaccine preventable diseases. There is a lack of trust in government agencies, CDC, health departments, etc. We have a culture where celebrities are trusted more than experts and scientists. And then states that have easy exemptions also have lower coverage rates. So how can you let's say you want to talk to your neighbor about immunizing their children. Well, the first thing to do is to listen. You can't, even though God knows I want to do this, you can't go in there and say, I know best, you should be vaccinating your child, it's child abuse not to, et cetera, et cetera. You need to listen. You need to presume that they will accept vaccination if their concerns are validated and addressed. So you need to talk about how vaccines are safe, how they're monitored all the time, how side effects are very rare, and that children do die or are seriously injured from these vaccine preventable diseases. If your neighbor wants to, well, yeah, I believe in vaccination, but it's too many at one time. I don't want my child to have that many shots. I'm just going to spread them out. Again, you can calmly explain, that's okay, but your child is then at risk for a longer period of time. Share your experiences about immunization. I always tell this story. I'm aging myself, but when I was born, there was no polio vaccine. I was about 2 when it came out, and my mother talked about how she and all the other mothers are fighting to be first in line to get their children vaccinated because they had seen the devastation of polio and how a child could be fine going to bed and wake up and need to be put in an iron lung. Luckily, we don't see that anymore, but the possibility is still there if not enough people are vaccinated. Have follow-up conversations and you can provide additional resources. This August is National Immunization Awareness Month, and you can find a lot of resources at this site. It's in because of the month, but it's there all the time for you to look at if you do want some resources, either for yourself, your family, or acquaintances. So I don't know if you can tell, but I'm from New York. I talk fast, but I did make it through all that in 45 minutes. Sunda, are there questions? This is my contact information, and this is the QR code for the Dell Center. So, but you'll have these slides.
Yes, yes, we will definitely have these slides on our website. Thank you for a great presentation, and we do have some questions.
Do you want me to stop sharing?
Sure. I think.
Okay, I just have to figure out how to do that.
Just leave it. I think it's fine.
Okay.
Okay. So the first question is, and this goes back to your very first slide, I believe. Do we have differing success rates with each of the different types of vaccines? So that's one question. Second is, are there evidence shown benefits to utilize certain modes? For example, mRNA versus inactivated vaccine.
Okay, two great questions. First of all, yes, some vaccines are more effective than others. If you remember way back to before we had a COVID vaccine, and we didn't know how well it was going to be, how effective it was going to be, we said we would be happy if it prevented 50% of basically hospitalizations and deaths. It turned out it was much, much more effective, 85% or so. There is a malaria vaccine. It's not real great. It's only protects about 38% of children given it. However, that is such an improvement over not being vaccinated. So yes, vaccines can vary in how effective they are. And that's part of the consideration when FDA decides whether to license something or not. In terms of types of vaccine, and you know what, since I have these slides still up, I can go back to that one. Yes, there are differences. The first vaccines that we had were inactivated. And as you can see, we still do have some that are inactivated. They are probably the least effective of vaccines, those in subunit. It's hard to say about mRNA. We had a great success with COVID. Will that be the case with other viruses? We don't know yet, so it's a little hard to compare. However, the gold standard really, if you can make a vaccine for a given pathogen, is the live attenuated, because again, I'm going to use virus. The virus is actually replicating. It's making more of itself in your body, just like the wild type, the kind that makes you sick would. So your body really ramps up a great immune response to it. So again, that's the gold standard, but we can't always do that.
Great, thank you. Second question, also a very good question. What do we say to anti-vaxxers when they claim that the mRNA vaccine contains graphene and it's harmful to the body?
Graphene, huh? Just as an aside, you may have heard the myth that the COVID vaccine contained microchips so the government could follow where you were going, which I always thought was amusing because with your phone, anybody can follow where you are. We have no privacy anymore. The COVID vaccine, no vaccine contains microchips. You know, like with anything, you have to pick your battles. There are some people you're never going to convince. There are other people who truly have questions, are open to it. They've heard stuff. And so, you know, you can look at every vaccine and has a vaccine information sheet, a VIS. If you've gotten vaccines, if your children have, you've been given that. Come to think of it, I wasn't given that for the tetanus, diphtheria. Oh, well, you should be given it. in that, it will tell you exactly what's in the vaccine. You know, that's all you can do. If somebody's not going to believe that, maybe you move on.
Good answer. Thank you. Okay, let's see. Hepatitis B. Do you think it's important or necessary to test for hepatitis B before vaccination for people over 30 years old? So, for example, that they maybe did not have a childhood vaccination.
Right. That's a good question. It really depends on what your risk it's a cost benefit question. I mean, there's no harm to getting tested, but it costs money. And so it really depends on your risk factors. If you don't have, if you're not an PWID, you know, person who injects drugs, if you are not of Asian descent, where mother to child transmission of hepatitis is very common. You know, if you're not a medical professional, if you haven't had a needle stick, it's probably just not worth testing. If you do have antibodies to hepatitis B because you've had hepatitis B in the past and you get the vaccine, it's fine. I mean, it's not going to do you any harm. It's just going to cost some money. So it just depends on the circumstances.
Okay, great. So there's a follow-up question. I think this is a bigger question. So how important is testing for uninsured people? I guess assuming that they may not have had childhood.
You know, right now I am involved in a research study, and it's not really research, it's more of a service study, looking at folks who are unhoused, who are at higher risk of hepatitis B and C, and we test them first, and then vaccinate against hepatitis B, or we're working with Healthcare for the Homeless to get them into treatment for if they're hepatitis B or C positive. But again, it's just really not important. It's a cost issue. If you're going to get that hepatitis B vaccine for free, but you'd have to pay for testing, get the vaccine, you know.
Yeah.
Again, there's no harm in being vaccinated if you either already have antibodies or if you are currently infected. It won't do any good if you're currently infected, but it won't hurt you either.
Okay, great. Next question. So this is a fairly specific question to get your view on the COVID booster. I've heard the current booster is not very effective against the current strain, so people should wait until the new booster comes out later this fall. Do you agree?
Again, it depends. So if you can, I would say wait. I am waiting to get that. You know, it should be a month or so. It's not that much longer. However, if you are at higher risk, should you get infected, talk to your healthcare provider about what he or she recommends. There are some people, it's probably worth getting it now. And yes, the new booster should be more effective against the strains that are currently circulating, but the old boosters are pretty good. And in fact, we're seeing new strains come out. You know, it's like the problem with flu. The virus just mutates so quickly. And it takes a while to manufacture vaccines, especially for flu. You know, we're guessing in the spring what flu variant is going to be circulating in the fall. Excuse me, in the fall. Sometimes we have a good match, sometimes not so much, but still worth getting, even if you're only 50% protected.
Yeah.
So again, it depends on your particular risk factors.
Follow-up question, I think, to the previous little discussion. So the question is, how has this affected the homeless population in Texas or other states that you have observed? And I'm thinking that maybe they're referring back to whether to get the vaccine where you may have already had the disease or not. So I don't know if you want to add anything
for
to
hepatitis B. Well,
yeah, I think it's back to that question.
Yeah, I mean, the unhoused population is at risk for a lot of things. If if they want to get vaccinated against anything that is recommended by CDC, there are places you can go to get vaccinated. Now, it's for free for COVID. The public health emergency has ended, but there are ways you can still get vaccinated for free if you're uninsured. For other vaccines, there is the adult safety net, but it doesn't cover as many adults as, for example, the Vaccine for Children program. In other states that have expanded Medicaid, if you are eligible for that, then you could get your vaccines through there. Now, I will say, however, that if you are living day to day on the streets, getting vaccinated may not be your top priority. And so that's another reason why the unhoused population has lower vaccination rates. We did see during COVID that there, because shelters limited the number of people in order to stop spread, we did see some outbreaks, but then again, we were seeing them in everybody. So, yeah. So bottom line, yeah, I mean, it is harder for them to get vaccinated without insurance. There are resources out there, but they may be hard to access and not top priority.
All right, I think we have time for one more question. In Virginia, we do have religious exemption for school immunization requirements. Often I find parents getting these exemptions, however, their children have had other vaccines. How can it be justified to only pick and choose which ones their children get? How do you deal with these parents? This is a hard question to answer.
Yeah, that's a hard one. I'm not sure that this counts as a legitimate religious exemption, but I have been asked in the past, I don't even remember what vaccine it was, this was a couple of years ago, by a religion that prevents it wasn't cows, but it was fetal calf serum. I don't even remember now. But let's say that it's a religion that promotes vegetarianism and no animal products. Sometimes if you're growing viruses in culture so that you can grow it up and inactivate it or attenuate it, whatever you're going to do to make vaccine, the virus to grow in cell culture requires fetal calf serum, which is just what it sounds like. And so you might have a religion exemption to that vaccine, but not another vaccine that doesn't use it.
Interesting.
I kind of doubt that happens real often when people are in the situation that you're talking about. And yeah, I mean, it's hard to justify accepting some vaccines over others for school immunization requirements. But on the other hand, who's monitoring it? I mean, I kind of doubt the school would say, wait a minute, you want an exemption for this vaccine, but not others? I just don't think they're going to do that because they got bigger fights. So yeah, sorry, I can't be much help on that one.
Yeah, no, I think that's a good answer and very realistic. Yeah. I think we are at time, so I just want to thank everybody for attending the webinar. And of course, thank you, Dr. Troisi. This is great information. Just remember that we do archive all our webinars on our website at msdcenter.org. And I just want to plug in just a little bit of information for our next webinar, which is with Dr. Peskin, and her title is going to be Evaluation of Texas Opt-in Policy for Sex Education and Abuse Prevention on August 31st from 12 to 1. So you will be receiving an email about this webinar, and we hope to see you then. Thank you all for joining us, and have a great rest of your day.